My name is Cesar Pellarano. I am a preventive cardiologist, and I've been doing preventive cardiology now for well over 10 years. So I have a lot of topics that interest me as far as preventing heart disease. As the previous speaker said, I believe cardiovascular disease is totally preventable if we get our patients to be compliant with our recommendations. Those of you who have heard me speak before have seen this slide. Superior doctors prevent the disease, mediocre doctors treat the disease before it's evident, and inferior doctors treat the full-blown disease. And doctors here are not meant to be a particular individual doctor, but rather the state of medicine. This quote comes from a Chinese medical text about 5,000 years ago. And what is sad is the fact that the state of our medical system in the U.S. now is actually the third line. People don't wait to go to the doctor until they're sick. And I hope that conferences such as this start shifting the medical horizons back to prevention. So what do we know about heart disease in women? Well, coronary artery disease is the single greatest killer of American women. In fact, it kills about one every minute. And it's a bigger killer than the next 7 causes of female mortality. For every woman that dies of breast cancer, 10 die of cardiovascular disease, and that is a real stat. In 2005, 42,000 women died of breast cancer. Same year, 92,000 died of strokes, and 332,000 died of heart attacks. And more women die of cardiovascular disease than the male counterparts. You're going to see that line about 3 or 4 times in this lecture. Because cardiovascular disease is more prevalent in men, but more women die of cardiovascular disease than men do. So how did we get into these hormones and preventing heart disease in general? Well, we know that premenopausal women are generally protected from cardiovascular events. It's very rare that we see a 35, 40, 45-year-old woman with an acute MI. But we hear about guys in the gym all the time. They're on the treadmill or on the bike. They keeled over and died. But yet, when women become postmenopausal, they develop the cardiovascular disease actually at the same rate that men do. And more women, as I said before, die of heart disease than men do. So therefore, since they're protected premenopausal, are the hormones really cardioprotective? I want to talk about 2 big studies here that you probably heard. KEEPS, which is the Chronos early estrogen prevention study. The results are not even a year old. They just came out last October. And all of you have probably heard of the WHI, the Women's Health Initiative, which is the one that really created most of the guidelines for the use of hormone replacement therapy in women. WHI, I'm not going to spend a lot of time on these studies, had 2 major arms. One was estrogen alone, and the other one was estrogen and progestin. As you can see there, both of the studies were ended early because of adverse findings, heart attacks, breast cancer, strokes. The estrogen plus progestin was actually stopped in 2002 after only 5-year follow-up, and the other one lasted almost 7 years. The third leg, obviously, was placebo. So we're going to talk about the WHI estrogen alone, mostly. It was a randomized study, and it was in, what I liked about the study is that it had 10,000 women, and it was in 40 clinical centers in the United States, postmenopausal women, but the biggest flaw of the study was that they were all older. I think the average age was in the 60s, and they ranged from age 50 to 79. And the women were randomly assigned, given 0.625 milligrams per day of Premarin, or they were given placebo. The unfortunate thing is that every one of these studies that we have are all with synthetic hormones. So what we really need are some studies with bioidentical. Personally, I never write for synthetic hormones. In fact, when a woman comes to my office and she says, I want my insurance to pay for my hormones, I'll say, well, you have to get the prescription from somebody else. So what were the outcome measures of the WHI? Well, they wanted to look at the incidence of coronary heart disease, non-fatal MI, and death. Invasive breast cancer incidence was looked at as safety outcome. And then the global index of risks and benefits were also looked at were cancer, stroke, pulmonary emboli, hip fracture, and deaths from other causes. The results, the study was ended early, and this slide's a little busy, so I made it easier. The conclusions from the WHI was that the use of estrogen increased the risk of stroke, decreased the incidence of hip fractures, and did not affect the incidence of coronary heart disease. And what happened was that the placebo groups really weren't that much different. So they came out that initially that there was a possible reduction in breast cancer, and then in 2010 it said that there was a higher incidence of breast cancer. Remember, they stopped the study in 2004. But what most people don't realize is that in the arm of the study that was estrogen alone, there was actually a reduction in breast cancer. But it was all grouped together with the estrogen and the progestin group. So therefore, we got the bad name for estrogen. That should not be recommended for chronic disease. And this is what I call created the original estrogen panic, where most women just did not want to have estrogen at any time. They actually came out with recommendations. And they actually gave the definitive answer in estrogen use back in 2004, what all the doctors would follow. And it basically said, you should not use estrogen because it causes breast cancer, has no benefits in heart disease. But once again, this study really looked at older women. And we never looked at the early postmenopausal woman. Guidelines actually came out of WHI, which is basically that hormone replacement therapy should not be used for prevention of heart attacks and stroke. It can be used in other causes, but with a lot of caution. And they actually said that you shouldn't even give it to women that have existing coronary artery disease. But it could be used short-term to treat postmenopausal symptoms. But once again, they discouraged the long-term use of estrogen because of the higher incidence of stroke, breast cancer, and heart attacks. So basically, it was these guidelines that are really being followed out there by the majority of doctors. But on the other hand, we all know that estrogen actually does some pretty good things. Raises HDL, lowers LDL. Even though it promotes coagulation, it does other anti-inflammatory stuff that's really pretty good for your vascular tree. It relaxes the smooth muscle, dilates the blood vessel, and soaks up a lot of free radicals. So it's really anti-inflammatory in many of its properties. So we've got this stuff that does all of these good things, but yet we're blaming the fact that it causes all of these other problems. So now we have Chronos. It's actually KEEPS, which is Chronos Early Estrogen Prevention Study, always been referred to as Chronos. And the results of this are not even a year old. They just came out in October. The problem with KEEPS is the fact that it only had 700 women, where WHI had 10,000. And KEEPS is a 4-year randomized study where they gave people transdermal estrogen and oral estrogen, but they used much lower doses than in the WHI. And the results, as I said, just came out in October 2012. The difference is that they did give progesterone to all of the patients that were taking estrogen. So they had no estrogen alone leg. In KEEPS, the trial did not include women with evidence of cardiovascular disease. In fact, they all had very low calcium scores. The levels of cholesterol, triglycerides, and all of the lipids were so low that none of the women even required any therapy. And they really didn't look at people with smoking habits and obesity. So therefore, this study only looked at low cardiovascular risk women. It was kind of a pre-selected group, in my opinion, to try to get very good results. Here we had 700 patients as opposed to 10,000. They were given 0.45 milligrams of Premarin as opposed to the 0.625 that was given in WHI. And by the way, the women in KEEPS with the lower dose of estrogen actually had better blood pressure results than the women in WHI. And they attributed that to the lower dose of estrogen. Some women received Clemara patch. And as I said before, all of the women that were given estrogen were also given progesterone. So what were the outcomes? They looked at symptoms of menopause, primarily the hot flashes and night sweats. Looked at bone mineral density, sexual function, libido, lubrication, pain, and intercourse. And the two cardiovascular points that they looked at was CIMT, which is carotid endomedial thickening, and coronary artery calcium score. So these are really the only two. By the way, I'm not discussing, there was another leg of this study that looked at Alzheimer's in KEEPS, but I'm really not addressing that in this lecture. But I'm not ignoring it, just want to let you know. And the results, as expected, when women were given estrogen, they felt better. A lot of the symptoms of menopause were better. Hot flashes got better. night sweats got better. And they had very favorable effects, just like they did in WHI, as far as hip fractures and as far as bone density. Sexual function seemed to get better. There was better lubrication, decreased pain with intercourse in both of the groups. However, the transdermal group had improved libido over the oral group. But what about CIMT? When we look at CIMT, there was really very little difference in the two groups. And they actually came out saying that they're really not statistically significant, which is probably true. However, the trend in all of these women was improvement in the CIMT. So even though the changes that we saw were not really statistically significant or enough to change a lot of the guidelines, they all seem to get better. I'm also going to talk about another study, which is called the Danish Group, which I'm going to mention because that's the study that most of the people who want to tout estrogen as preventing heart disease, they use that study. But the bottom line was that there was no statistically significant improvement when we looked at the CIMT in all of the people in KEEPS. Coronary artery calcium, again, the women were pre-selected. Some of them have calcium scores of 0. And the highest calcium score was 50. So for all intents and purposes, these women were pretty clean of coronary artery disease. However, we did see some trends here also, that the people with very low calcium score had minimal increases in their calcium score. And if you look at the slide, it says 10%, 12%, and then 14% in the placebo group. Again, not enough to make it statistically significant, but once again, we see this trend that when women are given the estrogen, it seems to be getting better. When we looked at the women that had the higher calcium scores, the worsening of the calcium score was also worse. But that's what we expected. They had higher calcium scores to begin with. So what were the conclusions that we got? Well, after 48 months of treatment, there were no apparent effects or deleterious effects as far as the progression of atherosclerosis in these patients. And there was no statistically significant difference in the rates of MI, stroke, TIAs, venous thrombosis. And again, no significant change in the CIMT.